Welcome to the duodenal switch and SIPS video info bit. The duodenal switch procedure, or DS for short, was first done in the 1980s with an open surgical technique. Similar to gastric bypass, these open surgeries carried with them a high complication rate. Within the last decade, however, these operations have been done with a minimally invasive laparoscopic technique, which greatly reduced complication rates and reduced recovery time significantly. Within the last few years, modifications have been made to the duodenal switch, most notably being the SIPS or SADI procedure, which reduces the number of small intestine connections that need to be made. This has reduced risk even further. Before we get on to talking about the SIPS and duodenal switch, let's quickly recap once again how surgical weight loss works. There are two categories of procedures, restrictive and malabsorptive. Restrictive procedures work solely by reducing the effective size of the stomach. Both the lap band and the gastric sleeve are restrictive procedures. After one of these procedures, a patient will still absorb all calories they consume, they will simply consume fewer calories because they are getting full earlier. The restrictive procedures are covered in separate info bits. A malabsorptive procedure, on the other hand, incorporates not only a reduction in the effective stomach volume, but also involves bypassing some amount of small intestine. After a malabsorptive procedure, a patient will typically not absorb every calorie they consume, depending on the amount of small intestine getting bypassed. The duodenal switch, SIPS or SADI procedure, and gastric bypass fall into this category. The original duodenal switch can be thought of as a gastric bypass, but instead of making a pouch and leaving the rest of the stomach, a gastric sleeve is done instead. Much more intestine is typically bypassed in a duodenal switch than with a gastric bypass, which can lead to even greater weight loss, but also can increase risks associated with malabsorption, such as vitamin or nutrient deficiencies. As you can see in the diagram, there are two connections that need to be made in a duodenal switch, encircled here in red. Keep this in mind as we look at the SIPS, or SADI procedure in the next slide. The SIPS procedure, which stands for stomach intestinal pylorus sparing, takes away the need for one of these connections by simply pulling up a loop of small intestine and connecting the side of it to the gastric sleeve. It is also sometimes called the loop duodenal switch, or SADI procedure. These are all the same operation. Each connection that is made in a surgical weight loss procedure increases the risk a small amount, so eliminating one of these connections is beneficial due to a slight reduction in risk over the standard duodenal switch. Aside from this, the risks and outcomes of these two operations are fairly similar. For pros of DS and SIPS, it has the most power of all of the surgical weight loss procedures. Because of this, most studies show that it offers the best long-term weight loss as well. Likewise, SIPS and DS offer the highest remission rate for type 2 diabetes, in some studies as high as 95%. Next, since the stomach is not directly connected to the small intestine, the risk of a marginal ulcer that exists in a gastric bypass is eliminated. And lastly, after SIPS or DS, the entire stomach can still be accessed with a scope, unlike with a gastric bypass. As far as cons go, the complexity of this operation is similar to gastric bypass, which in turn makes it more complex than sleeve or band. Due to the fact that more intestine is bypassed, the risk of vitamin or nutrient deficiencies is even higher than with a gastric bypass, and these patients must commit not only to lifelong vitamin supplementation but also to having yearly blood tests to check vitamin levels. Next, similar to gastric bypass, SIPS and DS are not reversible. And lastly, specifically with the SIPS procedure, it is relatively new and not time-tested, and most insurance companies do not cover it. Let's take a look now at the main short-term complications seen after SIPS or DS. They look similar to those we saw in gastric bypass. Mainly staple line leaks and bleeding. As with bypass, staple line leaks after SIPS or DS could occur earlier and be more aggressive than with gastric sleeve. The other main short-term issue to watch out for is bleeding, which occurs in around 0.5%, or 1 in 200 cases. For the long-term complications, there are a few differences between these operations and gastric bypass. The most notable is the risk of serious vitamin or nutrient deficiencies. Since the amount of small intestine that gets bypassed is increased significantly, so is the risk of these issues. Therefore, patients who opt for the SIPS or DS must make a commitment to regular follow-up office visits and yearly ongoing lab work. Next, since SIPS and DS both incorporate the gastric sleeve, there are similar GERD risks involved. The risks of internal hernias or bowel obstructions is similar to what we saw for gastric bypass. The mortality rate, however, is slightly higher, with most studies showing up to 0.5% or 1 in 200. As for the procedure details, the typical operative time is about 2 hours. During the procedure, 5 to 6 small laparoscopic incisions are made, and a camera is used to perform the operation. Most patients can go home the morning after surgery. After surgery, the diet progression is the same as for gastric sleeve and bypass. Namely, patients must follow a liquid diet for 1 week, followed by pureed food for 3 weeks, and then advance to solids. Typically monthly visits are required in the first year after surgery, and although a live visit is always preferred, we can arrange for virtual video visits for our out-of-town patients. Several of these visits in the first year will require blood work, so arrangements will need to be made for virtual visits so that you can have your labs done locally. 2 visits are typically required in the second year, and ongoing yearly visits required thereafter. With regard to time off work, most patients with a non-lifting job can go back in 1 to 2 weeks, while for a lifting job it's usually 3 to 4 weeks. Thank you for watching the SIPS info bit. For more information go to journeylight.com/SIPS.